Hello and welcome to the EMSNation podcast. I'm your host, Faizan Arshad. Today I am very excited about our guest, Dr. Craig Manifold, who is exceedingly distinguished in his fields of not only emergency medicine, but the subspecialty of emergency medical services and medical direction. Dr. Manifold serves as the EMS Medical Director for ground, helicopter, critical care, tactical, fire-based, third service, hospital-based, private, as well as not-for-profit agencies in Bexar County surrounding the areas of San Antonio, Texas, and also is an assistant professor in the Department of Emergency Health Sciences at the University of Texas Health Science Center in San Antonio. His career in emergency medicine started as a volunteer EMT firefighter in his hometown of Stewartstown, Pennsylvania. He enlisted as a medic in the U.S. Air Force and transitioned to air medical evacuation and also became an instructor. After pursuing medical school, he applied for a residency with the Joint Military Medical Centers in San Antonio, Texas, and after service with the U.S. Air Force and deployments including Operation Southern Watch, Noble Eagle, and Enduring Freedom, he transitioned to civilian emergency medicine in Texas. Dr. Manifold is presently serving as the EMS Committee Chair for ASAP, the American College of Emergency Physicians, and is also a board member of the National Registry of Emergency Medical Technicians. Colonel Manifold continues his military service as a joint surgeon for the Texas National Guard. So just a little bit describing Dr. Manifold. He's truly an inspiration, and I actually consider him to be a personal mentor. I'm really looking forward to hear what you all think about this show. So we start off by talking a fair bit about the current DEA legislative efforts regarding the limitations or challenges to the pre-hospital administration of controlled substances. So if you did not know this was even an active issue, tune in because Dr. Manifold breaks it down, tells us all about his team, as well as the current House and Senate bills which are on the floor. We transition the conversation to talk a fair bit about EMS physician billing and the new subspecialty of EMS physicians. And we banter a little bit about the model in the U.S. versus Europe and this whole idea of the retrievalist or the rescue and response physician. So definitely some interesting conversation there. We also talk about the future of pre-hospital procedures such as REBOA, and then also give a national update on spinal motion restriction. Finally, we really dig deep into one of Dr. Manifold's jewels of an EMS system, which he describes as an EMS-based fire system. So if you're not understanding the reference right off the hand, let me just explain. There are multiple models of EMS services and operations, etc., throughout the United States and indeed throughout the world. In the U.S., a very common model is referred to as a fire EMS system that employs fire medics that are both cross-trained in various degrees in fire mitigation as well as pre-hospital medical response. So given the number of structural fires is decreasing across the country while the number of medical calls is increasing, he flips the common paradigm on its head and describes the efforts to build an EMS-based fire service and all the challenges therein. We also briefly talk about the advances in pre-hospital stroke care and just introduce quite suspensefully a brand new NAEMT course that he and I are working on, titled AHDR, All Hazards Disaster Response. So with that, folks, stay tuned, enjoy the episode, and we'll catch you on the flip side. Welcome to the show, Dr. Craig Manifold. We are so excited to have you on the line today, and you are joining us after working an overnight tour, night shift. It's now 9 a.m. in San Antonio, Texas, and we sincerely appreciate your sacrifice and your efforts on joining us during Memorial Week on EMSNation.
Faison, thank you so much. It's not a sacrifice whatsoever. It's a real pleasure to be with you, and I admire you and the things you're doing with EMSNation and trying to get additional folks involved in this type of educational process and spreading the word. So it's really a true pleasure. And then, night shifts are just part of the deal for us in emergency medicine and emergency medical services, that we still have to be engaged, and we're open 24/7 and provide that service to our patients. And so it's just the way it is. I enjoy the night shift, but as I get older, they're not nearly as much fun as they used to be and things like that.
Very well said, sir. Again, so excited to have you on, and such humility in how you present yourself. We have introduced the audience to a little bit of an introduction about you and your accomplishments. I just wanted to start out the show by saying that in the last Eagles conference, you were presented with the Michael Kopis Leadership Award, which was very exciting for me since I know you personally, and I was hoping you might start off the podcast by chatting a little bit about Dr. Kopis.
Well, I would be happy to, and it was quite a surprise and such an honor that Dr. Pepe and the Eagles bestowed upon me, and it's one of those things where I certainly don't feel that personally I can live up to the legend of Dr. Michael Kopis. I've only met him personally briefly through different meetings and EMS interactions, but so many of my colleagues and personal friends have a great admiration, as well as I, for the things that he has done early on in this profession of emergency medical services. And certainly on the West Coast, he's had a tremendous influence and a dedication to the patient aspect of care and patient-oriented or patient-centered care, which I try to emulate every day, that the things that we should be doing should be based around what is good for our patients, not necessarily what makes life easy for us or better for us as the EMS physician or the EMS provider, but how we can make it better for our patients. Dr. Kopis is, again, an esteemed physician who's had a wonderful career and still to this day impacts pre-hospital providers throughout the United States and the rest of the world. And so it was truly an honor to receive the award in his name. And I certainly hope in some little way I can live up to those expectations. Thanks.
Very exciting. Every May, ACEP has a LAC conference, a Legislative Affairs conference in Washington, D.C., and this May was no different, and you were representing as the EMS committee chairman, and there are some issues, legislative issues, I should say, that are very pertinent to EMS, especially in regards to controlled substances.
Absolutely, and this is one of my current passions, to be able to share this information. And so if I go on too long talking about this topic, you'll just need to shut down and do this. But the passion surrounds this, and if I could take a little bit of time and give some of the background regarding the Protecting Patient Access to Emergency Medications Act of 2016. It's currently a House Bill 4365 and a Senate Companion Bill 2932 that are in our federal legislature, going through the processes of review and committee hearings, and hopefully will be enacted with our current legislature. This originally started with discussions from representatives of the American College of Emergency Physicians and the National Association of EMS Physicians, NAEMT, and a few others, of trying to work with the Drug Enforcement Agency to assure that we were going to be able to continue our standing orders with controlled substances. And what that really boils down to is the DEA identified that they were going to be reviewing and implementing new rules associated with EMS. had obviously heard from our profession and our industry that the Controlled Substance Act and the DEA rules didn't really fit well with our current structure of providing emergency medical services, and they actually wanted to help us by reviewing and providing us a set of regulations that could be consistently applied throughout the United States and enhance the care that we provide as it comes to controlled substances, while minimizing diversion and all the other issues that are surrounding controlled substances. And in their research and in their discovery, and the folks that we talked with in the Office of Diversion Control, they identified that this Controlled Substance Act that was written in the 1970s, which was early on in the very early stages of EMS, and EMS had not really developed much as a profession at that point in time, and as to the point it is currently, they just weren't able to keep up with those changes. But what they found was in the Controlled Substance Act an actual specific requirement that in order to administer a controlled substance, it requires a physician order, typically in a written fashion, in order to do that. And as they explored that, they identified that there was no way of getting around that process, because when they make the rules, they have to follow the law that's been enacted. And the veterinarians have been successful in carving out a section and promulgating a rule that met their needs through legislative efforts. And when we had discussions with the folks representing the DEA, we came to the conclusion that we weren't going to be able to work around that concern of the standing orders, and we felt that that was a potential change that would have such a significant impact on EMS providers and our patients that we needed to go the legislative route to change that, so we would not have an impact on our current practice of emergency medical services. And so thus was born the work and the language for House Bill 4365 and Senate Bill 2932, and the organizations and stakeholders involved to look at that. So the current legislation, again, entitled Protecting Patient Access to Emergency Medications Act of 2016, as it's introduced, protects that ability for us to be able to utilize standing orders. In other words, keep our protocols in place as EMS medical directors and EMS providers in the field would be able to administer the controlled substances based upon those protocols and standing orders. In addition to that, it also helps with identifying the single registrant with the DEA, being the EMS agency, where they have the control, the management of the employees, and the policies and procedures to be put in place to manage the movement of the controlled substances, as well as a few other smaller entities or issues involved with controlled substances. And so very important to our industry. And right now I'm very proud to say, after a lot of work on folks such as Ritu Sani, immediate past president of the NAEMSP, and the current board members, and as well as the National Association of EMTs, have been the big movers, along with the American College of Emergency Physicians, to put these things in place. And we have well over 100 co-sponsors for the House bill, and the Senate bill is gaining traction as we speak. And so my urgency and my call to arms for our profession is, if you've not already spoken with your federal legislators in the House or Senate, please do. Make sure that they understand the importance of this. Ask them to sign on as co-sponsors and follow the progress of this. Now, I mentioned just a few organizations who we've met with and have had coordination meetings and working through this process, and the lobbyists to help engage this process. But there are many, many other organizations who've been engaged and involved and supportive of this, and we always welcome the feedback and certainly the encouragement of other agencies or other organizations' members to participate in this legislative process. It's your chance to dabble your toes in the field of advocacy, which is very important. And for those of us in EMS, this is one that will have a direct impact on our ability to care for patients. So please, 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 if you haven't already done it, go talk to your legislatures and follow this process until we get these this passed into law. So that's my story, and I'm sticking to it.
Amazing. Thank you, sir. I think there's a lot to dig into there. Certainly the urgency of this issue, I think where we no longer be able to administer pre-hospital controlled substances either for the relief of acute pain or for intractable seizures or things along those lines, I would certainly cause a massive disruption across the country, and I think that would meet the technical definition of a disaster.
Yeah, absolutely. And to be very honest, I don't want to be a fear monger for folks out there. This has been the results of conversations, discussions with the DEA, and trying to determine the best route to fix this problem. I get the feeling when folks were looking at the rule-making process, they felt that they really didn't have much of a choice when it came to that, and they recognized the disruption that this would cause, and so therefore they didn't want to put a rule into place that would cause this. But we had to have a fix to the a solution for this, and we think that's in this particular case a legislative fix to get us started. Once this is passed, then there still will be a rulemaking process put into place with the DEA. So we'll need to have close working relationship with them. And continue to provide input and public comment as it becomes appropriate as well.
Fascinating. So what's the timeline both for the House and the Senate bills now?
If you talk to us as the stakeholders, it's as soon as possible. Right now we have, although I'm not aware of a formal meeting date or time, they're in the House. There is discussion with the Energy and Commerce Committee, and that it's under review, and their staff has provided some input. And so that's exciting for us, but we don't have a specific date for a hearing. But we are hopeful it will be during this legislative session that we can get this accomplished. And that's what our goals are, I think, around the country, and why you may be hearing more and more about this legislative action, and why it's very important for you to literally, once you hear this podcast or review this material, to learn more about the bill and call your legislature. And I might add, the American College of Emergency Physicians, National Association of EMS Physicians, NAEMT, all have information on their websites regarding this bill and the exact language and some other information that may be of interest to you. And then, as always, if people have concerns or questions, they're always happy to, or I'd always be happy to speak with them directly, and they can contact me, and we can make sure we have my email information available for them.
Perfect. Thank you so much, sir. So with every guest on the podcast, one of our last questions is, do you have any asks or requests of the EMSNation audience? And to me, Dr. Manifold, you are not shy. You are leading off the podcast with a call to action. So for folks who are listening, you don't have to wait till the very end. This is your call to action. We have an opportunity to make a humongous difference in the way we practice our pre-hospital care, and to ensure the integrity and standards are maintained, and advocate for our patients at the highest level. So in our show notes, we're going to include the references from Dr. Manifold's office, and some notes on how you can reach your own legislators to let them know how important of an issue this is. So thank you so much for sharing that, Dr. Manifold.
Oh, it's my pleasure. And again, it really is that call to arms, and thank you for this component of having a call to action for the folks who listen in on this particular educational topic. I think that's a great strategy, and thank you so much for doing that.
Now, there was also a subtle nuance in this particular bill, and that had to do with the DEA license coming from the physician EMS medical director and transferring some of that responsibility to the EMS agency itself. Can you talk a little bit about the significance of that and how that may affect us as a subspecialty?
Absolutely, because there has been some discussion regarding this particular topic, and when I look at the things that we do as an EMS physician, there are a few things that we have true management and control over, and controlled substance has been one of those areas. But as we looked and explored, I think the conventional wisdom became such that it made sense to transfer this responsibility if you will, from the emergency medicine or EMS medical director to the EMS agency. The EMS agency typically is an employer and employee relationship, is responsible for the policies and procedures and control and movement of the controlled substances. And it can be quite complex for some urban EMS agencies. They have to actually are required to undertake a distributorship license and things like that, which are really outside the scope of an EMS medical director and being able to meet all the assurances and the requirements that are there. So there was some discussion, but the thought leaders put into place and felt that the registrant to the DEA really should be moved over to the EMS agency. Again, they have direct responsibility for the management, movement, and employee issues that are surrounding this particular issue. I can share a personal story that some people may laugh at, and I look back at and laugh, but as I was initially appointed as the EMS medical director for San Antonio Fire Department a few years ago, during the transition period before I had a DEA license associated with the fire department, as it takes a little bit of time to establish that, we ran into a crisis and we needed some additional controlled substances, and I didn't want to abandon the city or our patients, and decided that I would go ahead and utilize my personal DEA number at that particular time and order the medications on behalf of the fire department so that we didn't have any disruption in our services. Well, lo and behold, a box of controlled substances is delivered to my front gate or my front door one day, and I go out and look at it, and I'm curious as to what this is, and I open it up, and it's a box of Diastat or rectal Valium.
Wow.
That was delivered to my front door. And so again, it was a little unusual, and we took care of things and made sure we had the right transition and documentation and paperwork done to complete that. But lo and behold, a second box appeared on my doorstep, and it was the same sort of thing. So not only did this raise questions in my mind, but my wife became very concerned as to why there was so much rectal Valium in the hospital. And so that raised a few questions, but it took us a little bit of time to get that issue straightened out, and we were successful in doing that. But a little humorous anecdote as to some of the complexities of this particular issue that's out there and things. And I would add, in our profession, we have to be realistic and honest to ourselves. We are such a large profession, and we need to support the DEA's efforts in minimizing diversion. And so any of these things that we can put into play, control procedures that we can utilize to minimize diversion of controlled substance, I think are critically important for us. And we certainly are very supportive of those particular issues that are out there. So.
Well said. Now getting into the EMS physician or the EMS medical director in itself. So a brand new subspecialty recently codified. The second board administration for the EMS subspecialty exam was just a few months ago in October 2015. How are we approaching at a national level EMS physician reimbursement?
So what a great topic and an interesting discussion that we're starting to have among EMS physicians and as well through our professional organizations. And I have to be very honest with you, I think we're in very early stages of changing the process. There are many different models out there currently. Some EMS medical directors receive a stipend. Some have an hourly wage. Some it's based on call volume. Some there are other type of formulations that are put into play. The reality of it is, though, there are very few places, particularly outside of large private organizations as well as large urban fire-based EMS systems who adequately reimburse EMS medical direction. And so as this profession matures, develops, and changes over time, I think this is one area where we will see that process in place. And so from a professional standpoint, we have to put a few things in place to help with this, and we need to educate our members about this, and we need to look to the future as to what are the ways that we can provide adequate reimbursement for EMS medical direction. I think most of us who do this job currently, we do it out of the passion for the things that we believe in patient care, or love of the pre-hospital or out-of-hospital environment. We're looking to the future and seeing the integration, the addition of mobile integrated health, community paramedicine concepts and things like that. So we will address it, but there are many variables out there, and there's no standardization right now. But we do need to find the ways to recognize, acknowledge, and reimburse physicians for their expertise in time in this field. Again, my emergency medicine duties working in the hospital currently are really what fund my passion for being in the emergency medical services realm, and I think there are many other physicians in that same boat. It's a select few who are able to seek full-time employment or relationships that provide appropriate reimbursement at the physician level who work in the EMS field and things like that. So what does the future hold? The National Association of EMS Physicians, American College of Emergency Physicians are currently having discussions to work on some joint policy statements, do some research, and figure out how we can address this component. Traditional physician reimbursement is based on patient care, and it requires a specific code that is developed, a procedural code that is submitted to the government, and then you are reimbursed at a particular rate for that service. And so we're starting to research that process to see what is in place currently, and then what are things that we need to do to establish perhaps additional codes that may fit our needs, get those things in place before additional reimbursement takes place. And then in addition to government reimbursement, there are the private insurance companies that we'll need to address and see how we can manage these particular issues. And then perhaps there are other structures for physician reimbursement out there, again, based on these hourly or volume type of processes are in place. But right now, the physician reimbursement is all over the map with many different ways and many different structures that is taken into consideration. And I think over the next 5 to 10 years, as the profession of emergency medical services physicians, the board certification processes matures, we'll see those changes in reimbursement as well.
Great clarification. Do you see a difference between the reimbursement for the administrative operations of an EMS service versus the actual pre-hospital response of an EMS physician? And the reason I ask this because our colleagues in Europe and Australia, especially in social media and on Twitter, will occasionally tease the U.S. EMS-based physicians in such a way that says that, you guys are not retrievalist or rescue physicians or things along those lines. But we're finding that as our subspecialty expands, that in fact physicians are responding pre-hospitally. Do you see the future holding designated ICD-10 codes for physician response?
Yeah, I think there will be. I don't know how expansive that will be or how limited it will be. But I think that's one of the areas that our professional organizations want to explore. Again, with EMS physicians, there is a response component. We're certainly not at the level of our European colleagues or Australasian folks, and it's I'm kind of smirking when you say they're making fun of us out there and things like that. That's a fun-natured piece, but I think we have a lot to learn from these other countries and how they pursue this. I mean, for a lot of emergency medical services physicians, what better life could you ask for than to be able to have your primary job as responding in the out-of-hospital environment? But again, right now there's no reimbursement model for that, and it's a different animal that we have in response. We have wonderfully trained pre-hospital personnel at the basic, intermediate, or advanced rather, and paramedic level. National Registry certification, oversight, critical care paramedics, mobile integrated health paramedics, flight response, wilderness medicine, all of the different areas, tactical, we could go on and on. So we have this wonderful profession of pre-hospital providers, and I don't want it to sound like we're going to have EMS physicians out running on every call and things like that. I think we have to strike the appropriate balance for oversight and physician response, but we'll get there, and that's part of the challenge of a young profession for us to continue to develop.
Absolutely, Dr. Manifold, and we certainly, after we're just concluding EMS Week 2016, want to recognize the amazing expertise of our pre-hospital colleagues and the amazing patient care they provide all across this country and indeed all across the world. And it's really in the nitty-gritty of defining a specific scenario where, a critically ill patient may in fact benefit from the physician-level care or expertise. You're doing some work in also with the ACEP EMS committee on the future of REBOA. And is that in the pre-hospital space or in the emergency department space? And by REBOA, we're of course referencing the resuscitative endovascular balloon occlusion of the aorta.
So I would say all of the above for right now. And my personal involvement is more on the administrative level and assisting the American College of Emergency Physicians as we have further discussions. In fact, recently we had representatives of the American College of Emergency Physicians, including the president, Dr. Jay Kaplan, Dr. Deb Farina, a board member, myself, Rick Murray, our administrative staff member, Dean Wilkinson, the executive director of the American College of Emergency Physicians, met with Dr. Ronnie Stewart and other members of the American College of Surgeons Committee on Trauma, looking at ways that we could continue collaboration and in this space of trauma care and trauma systems development. And one of the topics was exactly that, was a REBOA, a exciting and interesting technology that has had some promise and initial investigation in the military and is getting a lot of attention in the press, but again is a relatively new procedure and new from the standpoint of being used in not only the hospital environment but also in the out-of-hospital environment. Military members have reported some initial successes and they're continuing their research and technology development associated with it. A number of members of the Committee on Trauma, I remember particularly at Shock Trauma in Baltimore, have had increased experience and expertise with this. So it's very early on. I don't think we can definitively say what its role will be today, but we're gathering more and more information. We have some EMS fellows here in the San Antonio area from the military who received a recent grant and are going to be looking at access for REBOA. And so I think there's a bright future for it, but as with most new procedures or technologies, it's really a matter of trying to define when is it appropriate, where in the continuum of care should it be performed, is it out in the field, is it pre-hospital personnel and transport, is it in the emergency department, is it in the radiology suites, is it within the trauma surgeon's purview. Lots of interest, lots of space, but I think we will certainly need additional education, more research as we start to answer some of these questions. But it's exciting technology, and it's really amazing to think that through a central catheter type of technique that we can thread a catheter through the aorta and potentially block blood flow while we continue resuscitation for patients. At a recent military meeting, I was down at the Special Operations Medical Association meeting, and I won't be able to quote the numbers, but they did a comparison in looking at survival associated with REBOA as opposed to emergency thoracotomy. And emergency thoracotomy is something I'm quite familiar with. Back in the old days, that was something we did routinely. We don't do it nearly as much today. but the survival rate was markedly improved for REBOA as opposed to emergency thoracotomy. Now, probably some differences in the patient population that were utilized with that, but it was enough to catch my attention and recognize that this validates some of these areas of interest in the excitement associated with REBOA. And so I look forward to additional discussions, and there probably will be additional federal dollars put into this area because of the interest from the United States military to look at this technology and capabilities. But we've got a lot to learn. I don't think it's ready to be put out there in the pre-hospital environment today, but who knows what the future will hold for us.
Sir, do you recall if that military study was in regards to blunt or penetrating trauma?
I don't recall off the top of my head if that's so.
Okay. I was also at a lecture by Justin McLean at CCTMC this past March, and he was talking about operationalizing REBOA and the future of critical care transport of patients who do have a potential balloon up for definitive care. And I was just actually reviewing his slides in preparation to chatting with you. The 7 French catheter dramatically changes the paradigm of the REBOA and, certainly brings it to the emergency department and opens up the possibility of the pre-hospital space as well. And sort of the critical difference there is the 7 French, once you pull the catheter, you can essentially form a clot with simple manual compression. There's no surgical repair required of the vessel. But the interesting point was the 7 French was introduced by a company, Prior Medical Devices, which is based in San Antonio, Texas.
Yes. Yeah, unfortunately, I don't have any relationship with Prior. But again, I think it is an area, and you're absolutely right, that change in the size of the catheter is a true significant advancement for us when we look at Seldinger techniques. I think, Faison, if I could, I'll maybe make an aside here. In emergency medicine, over the last few years, particularly in sepsis management, central line access, there's been a lot of discussion about an appropriate placement. And in our institutions where I've worked, it's been essentially to do away with femoral access. And in fact, you would potentially receive a note from the infection control, the sepsis committee, and quality committee if you put in a femoral line unnecessarily or without adequate justification. It got to that level of interest. And when we start to look at these advances in pre-hospital care, when we look at REBOA, we look at ECMO in the pre-hospital environment, and some of these technologies that are coming down the line, I think we should be teaching, particularly our critical care transport folks, really they should have intimate knowledge of the femoral triangle and the anatomy, and not only know how to percutaneously access the femoral artery and vein, using ultrasound guidance, utilizing a cut-down procedure. All of these things, I think, are an area where we should be focusing on, because I see, if I were to look into the future, I think this is going to be our access into our resuscitation points, and so I think we should be having our folks spend more time getting to know that. Now, it's easy for me to say because I'm sitting in an office this morning that's literally 10 feet down from one of what I feel is a special gem of EMS service that I work with personally, the Bulverde Spring Branch in the Center for Emergency Health Sciences, where we have, I think, 5 unembalmed cadavers that are being used for training today for various organizations. And to have access to that and utilize that model for training is just an unbelievable asset for us to share with other members in our region. But I think, again, having a knowledge, a fundamental awareness of the anatomy of the femoral triangle is going to be our future.
Hey friends, I'm going to take a brief moment to pause the show and bring you a word from our sponsors. No, not the sponsors you may traditionally think of, but rather sponsors that are aimed to help eliminate healthcare disparities. This is a very special project I'd like to announce during EMS Week for folks to trial. It comes at absolutely no cost and is ultimately designed to optimize your training experience and help translate into improved outcomes within your community in relation to out-of-hospital cardiac arrest. Recently, a group of colleagues of mine and I had the pleasure of coming together and reviewing the science and literature on feedback in CPR, and the data pretty much speaks for itself. Dr. Bobrow, the State EMS Medical Director of Arizona, has done tremendous work on this, and we now know that all the major defibrillator companies come with some sort of active CPR feedback. Nevertheless, we are acutely aware that once you know a single EMS system, you know a single EMS system, and budgetary constraints are real-world problems and challenges. Not everyone can afford the defibrillator component to their device. So what have we done is designed a watch app for the Apple Watch called Perfect CPR. Now, we should be very important to state this is designed for training purposes only, but nevertheless, once a provider opens up the app using the accelerometer and gyrometer built into the Apple Watch, you will be able to get direct feedback on your rate, depth of compression, as well as recoil. So please check this app out. It is available at $0.00 in the Apple Watch iTunes Store and is called Perfect CPR. Please also find us and follow us on Twitter at Perfect CPR. Again, we're beta testing for this, very excited to launch during EMS Week at a cost of $0.00 and would love your feedback. We can all do a part to help improve the health disparities within our country, and feedback is definitely a requisite component to that. Check us out.
Very exciting future indeed, and I think it's always important to remember that we're focusing on evidence-based solutions. So it is exciting. We do yet have to establish the correct patient, the correct timing, positioning, a lot more data and research required for REBOA. But something that reached a tipping point in regards to our evidence base was spinal motion restriction. And in 2013, 2014, the evidence for longboard immobilization of our blunt trauma patients became too difficult to ignore. And almost state by state, we saw dominoes falling where the longboard immobilization was summarily eliminated. The longboard was relegated to an extrication-only device. And we started evolving the concepts of cervical spinal motion restriction or selective spinal motion restriction. What's the national update, sir? How are folks doing? What is our how is the tipping point? And were there any ramifications, lawsuits? People were afraid that everyone would be getting sued and things along those lines.
Yeah, what a great topic to discuss, and I describe this to my services and the folks I talk with, that we're in the middle of this culture change when it comes to spinal motion restriction, and it's an exciting time. It's amazing when we start to put, again, evidence and research behind some of our decision-making processes, what an impact and what changes it can have. So I think we're on the right path. But again, this is something that we've taught and ingrained in people in our education processes for over 25 years, since the beginning of emergency medical services, that almost everybody needed a spine board. I can remember when we were using short boards and things like that to start off with, and so it's ingrained in our educational, our testing and evaluation processes, and so we have to start to move away from that. So I think we're seeing that. I think it's probably an additional 3 to 5 years of culture change. We have some early adapters and folks who are very aggressive with this. I've heard a couple of agencies who have completely gotten rid of carrying any longboards. I think that I feel that there's still utility for the longboard. I think it's a great transport and potential extrication tool, and so I haven't done that with any of my services particularly, but certainly there's less utilization and more specific utilization for people with the increased risk for a spinal cord injury. And so this culture change, I think, will take some time. Our receiving facilities, we have to coordinate with them and make sure they're aware of this process. And so I think it's exciting for us to see these changes, but it will take some time for us to see completion. I'll tell you, one of my worries is that for such a long time, the longboard and C-collar were a visual reminder that the patient had not been clinically cleared, or their quote-unquote spinal cord was not cleared. And so when we took a patient to the hospital, they're on a longboard and C-collar, immobilized, we took particular precautions in moving and transporting that patient. Now today, where we may not have that longboard as a visual reminder, that patient still has not had their spine clinically cleared perhaps, and is being moved, and we get to the hospital and we say, here, ma'am, move on over to the board, or move on over to the gurney, or here, let me sit you upright, and things like that. So that provides some concern for me. As well, I think we need to make sure that our education processes start to look and provide more emphasis on our at-risk populations, such as the extremes of age, the pediatric and the elderly, who may have more risk, and then the subtle signs and symptoms that may be out there. Again, if you have a complete spinal cord injury, there's probably not a lot of impact that immobilization is going to have on that particular clinical process. But somebody who has those unusual symptoms of some numbness and tingling after a fall or a motor vehicle collision or other particularly blunt trauma, those are things that we need to take very seriously. We should not blow those off. And that just little unusual tingling or paresthesias or funny sensation that the patient's describing, we should consider them to have a potential of spinal cord trauma, and so we have to be careful with that. Now, the research is very interesting. It's very fun to watch and see as it develops, that we notice that the spine board may be doing more harm than good. Again, we talk often about skin breakdown. We're seeing from some of the early information that's being presented that there's actually less spinal cord movement, spinal column movement, when we secure the patient to the gurney as opposed to the longboard, where they can slip and slide and move around. So more and more of this information is coming out, again, as we look at this culture change that's associated with this. But it's, again, 25 years of education and pounding. You couldn't go through an EMT basic class without spending hours on spinal immobilization for us. And now we're transitioning to this spinal motion restriction. The National Registry of EMTs is addressing this and developing a policy statement, and we'll be looking at how they evaluate and examine this. I still personally feel spinal immobilization is a skill set that we should teach and examine, but certainly it does not have the same degree of emphasis that maybe we've had in the past. The interesting note are some of the policy statements that are out there, and if you follow this, you'll find that currently there's some differences in the leading professional organizations and the degree with which they address this concern. One is, I believe, the Athletic Trainers Association had put out a statement, and they have some unique circumstances associated with their injuries, and I was not involved with the development of that policy, so I don't know that I can comment clearly on that, but I think people should have an awareness of what that clinical policy identifies. And then there was also a joint statement from the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma that still recommended the utilization of spinal motion restriction and longboard immobilization in particular patients. And they went through a process that they were able to come to agreement in a few years ago, and we're very honored and proud to have that kind of collaboration among the larger professional organizations. During that time period, the American College of Emergency Physicians had discussions on this and quite heated debate during some of our committee meetings as related to spinal motion restriction. And from the American College of Emergency Physicians, who EMS committee was led by Dr. Sabina Braithwaite at that time, and was a lead person in helping develop this along with other members of the committee, felt that the American College of Emergency Physicians should take a little stronger stance on the spinal motion restriction component and identifying that it's the principles of spinal motion restriction. It's not a device. It's not a particular tool that has to be utilized or needed. It's the principles of spinal motion restriction, again, not limited or relegated to a medical device or tool such as the C-collar or longboard with that. I'm excited to say that we've had some initial discussions with these organizations, and as I mentioned before, the American College of Emergency Physicians met directly with the Committee on Trauma with Dr. Stewart, who's the chairman of that committee. And one of the outcomes of that was we recognized the need that there is a potential for a stronger policy statement if our three organizations would come together, that being the American College of Surgeons Committee on Trauma, ASAP, and NAEMSP, if we could come together with a joint statement. And so I'm honored to say that the initial process is in place. They're gathering some information, gathering in research, and each of the professional organizations are identifying members who will sit on that work group, and our attempt will be to come up with a policy statement that addresses this from these three organizations, and then pursue that, and again, hopefully develop that into a joint policy statement of all three organizations and have that readily available for implementation and providers and agencies to use as a resource. Again, that's early on in the development, but I think the timing is right, and my hope is for continued development and progression of this kind of a clinical policy and things. So I'm excited to see that moving forward. Again, it's never at the pace we all would like to see it, but these things need to be deliberate and well thought through to have a good clinical policy in place. So that's kind of where we stand on spinal motion restriction.
It's certainly exciting to see the evidence base influence the tipping point, and that resulting in a change in policy at a national level and amongst all these organizations. And the ultimate physiological principles rather than devices are prevailing. So Dr. Braithwaite was actually instrumental. She created several training videos which we use as educational tools in our service as we unrolled our new selective spinal motion restriction policy. So she certainly has been very influential. In regards to tipping points and things being memorable, 2 years ago, I'm going to go back to another Eagle story. I had just, graduated my EMS fellowship the year prior. This was the first time I had attended a conference. And you stood up. I had not met you personally yet. And you asked two paramedics to stand up as well. And you recognized them for being leaders in transforming a model that we had all been familiar with, but nevertheless, the prevailing situation and circumstances around us were changing. And what I'm referencing is the model that you've built in San Antonio, which is the EMS-based fire service, and we contrast that to different types of EMS infrastructures. So a fire-based EMS system is common. We have private EMS organizations. We have community-centered modeled EMS, various models of EMS. But in your service, you espouse the EMS-based fire service. Would love to hear your take on this. How did this become a reality and inspiration even, and how has the deployment amongst the rank and file gone?
So it's such an interesting topic, and it's amazing what semantics and changes in some of the verbiage can bring out in folks. And so I think the reality of it is when we look at the call volume and the resourcing that's required, that we all know and recognize in whatever type of mixed service we have that the predominant workload is related to EMS. Originally, over the last few years, I've heard it's an 80-20 split between EMS versus fire. This year I've heard of agencies that have had 90% EMS and 10% fire-related duties associated with that. But again, the resourcing, the training, the equipping are not in alignment with that. And so those prioritization of resources, I think, come into play. And I don't profess to think that we need 50-50 split or those sorts of things. I think we just need to we need to come in more alignment with where the workload is and what the requirements are to be able to successfully meet those needs. And so I'm a proponent of fire-based EMS systems and have a number under my medical direction and tutelage and guidance. And I think that there's a tremendous modeled and wonderful component that's there. But I also will prod the fire chiefs and look at training requirements and the resource things that's out there. But where this interesting concept of EMS-based fire service came into play was with a specific agency in Comal County, which is just north of San Antonio, called Bulverde Spring Branch EMS. And this was a long-standing volunteer service in a relatively rural community that has developed throughout the years and is in the expanding suburbs to the north of San Antonio. So we're seeing increased urbanization, suburbanization, and all the challenges that go along with that. And it came to a time of consolidation of the EMS agency and emergency services districts and the fire departments to be able to provide a concerted response to our citizens in the area. And so this is one of those things that I certainly cannot take credit for. This is a wonderful team of people who are engaged and involved in leadership, not only of the agency, but in the community, who see and recognize the benefits of this type of process. We provide traditional EMS response, typically a dual paramedic response. Occasionally we'll use EMT paramedic, mostly paid services with volunteers who supplement our activities. We have multiple fire apparatus involved. We have an educational component that I'm quite proud of and led by Scotty Bollitter as a world-renowned educator, is on the speaking circuit throughout there. A lot of people know Scotty personally, and our fire service personnel who provide the response. And so all of these things came into play. It was not an easy process, as you can imagine, to consolidate services, but it was built around the strength of the EMS service and the director, Michelle Salmon, and Chief Mark Southwell, as well as Scotty Bollitter, who were able to provide this corporate structure, if you will, of leadership, understanding, and primary service to the community, that they were able to put into play what I consider, or what I call, the EMS-based fire service, because it was really the EMS component that was driving the train, if you will. Now, again, the transitions were not easy, as you can imagine, consolidating a number of fire services throughout the county to be able to do that. But the benefits, as our leaders, board members see, is a improvement in efficiency regarding administration, decreased cost associated with this that goes along with that. But we were actually able to improve the benefits and pay packages of the firefighters who had previously been employed with other entities and bring them on board to provide a organizational structure that incorporates both fire and EMS services with that. Our goal would be to have dual firefighter paramedics throughout the organization, but we're not quite at 100% for that at this point in time, and we still value that workload of EMS requirements in our professional organization. But I have to give all the credit to Michelle Salmon and her team with being a leader in this area. Her expertise as a field paramedic, rising through the ranks, learning the administrative structures, and her commitment to her community She has gone out and built the relationships, again, with the board members of the emergency services districts, been active in the community, Chamber of Commerce, and the political leaders, as well, in building a team and building the support to put this organization together. And in addition to the municipal support, has gone out and hired a business development type of person who's responsible for fundraising and is able to utilize those resources to help enhance the services that we provide. And so today, again, we have a EMS or led fire service from personnel and training concepts who is able to provide a world-class educational center as well as mobile integrated health concepts with community paramedicine. In addition to having the paramedics dedicated to going out and doing in-house visits upon referral of members of the community or our fire and EMS-based services. We also have an in-house clinic that has been established as a 501c3 foundation called Acacia Medical Clinic. I serve as the medical director for that concept, and we actually see patients in our clinic who are underserved in our community and don't have means of other health care. We have mid-level providers and then that are paid members, as well as volunteer providers who come in and will provide follow-up primary care type of medicines and GYN, and then with complex cases we'll work with other community organizations and other hospital services in the region to see if we can provide them the appropriate evaluation and care. And so it's really, again, I describe as a gem of a service, but it's a number of people who have come together to recognize the community's needs, and the emphasis is on that caring aspect. And we see that not only from an EMS perspective, but from the fire-based response as well. So, and I'd be happy to try and answer specific questions, but again, Faison, this is an exciting team of folks who put this together. I'm just fortunate enough to be blessed as and being honored as the medical director for this service and providing some oversight and guidance, but it's really exciting to be engaged and involved and see all the people and all of the things that they do for the organization, as well, or primarily for the community that they're engaged in as well. So.
Very exciting indeed. I think this is not the traditional model of certainly fire-based EMS services where, across the country there may be some hierarchical differences or a strict distinction, whether it be in training or even in benefits and retirement packages and things along those lines. So very interesting model. As you were beginning to essentially cross-train or train all the boots on the ground, was there resistance from the fire side in learning the medical aspects of care, or how did you address any EMS providers who may not have had much experience with fire mitigation and things along those lines?
So it's, again, very interesting, and this is still a process and evolution. And so I would not say, again, that, you just turned a key and everything transitioned and it was smooth and wonderful. Michelle, I'm sure, could tell you about some of the bumps along the road. But in the end, the process has been very fruitful and very successful. I think from our EMS personnel and perspective, there was probably worry and concern and what their expectations would be. We've had a number of personnel who have transitioned and completed their fire certification and integrated completely. But we still have a few folks who have not done that. And we're very pleased with the services that are provided and the professionalism that they're able to do. We struggle with what are the standards that we should incorporate for, particularly for fitness and look at some of the gender issues and things like that, or discussions that we've had internally as far as policy making and things like that to help us. I think from the fire personnel, there was a significant amount of trepidation from a traditional fire service to maneuver into a EMS led type of organization. But we incorporated a number of the administrator leaders from the local fire services. And I should mention that prior to this integration, that there was a wonderful working relationship between the different agencies, and we were able to capitalize on that, of course. There still are some of our firefighter personnel that we have a challenge to make sure that they are maintaining their medical expertise and meeting their requirements in order to do that. In fact, I can tell you that one of my duties this morning is we were looking over and reviewing our credentialing processes to identify those folks who are a little delinquent and providing the appropriate response to make sure that they're getting their requirements done. And our requirements are pretty, I would consider pretty aggressive for the typical provider that's out there. And so we have great leadership with our battalion chiefs and our shift supervisors to make sure that our personnel are accomplishing that. And as well, I talk highly about our Center for Emergency Health Sciences, our education component that is, again, located in our central station and has multiple opportunities for people to take advantage of it. So.
And we'll link to the website of the Health Sciences Center in the show notes if there are providers out there that want to take a gander and see all the interesting educational initiatives you guys have put together. I think it'll be worthwhile. So we'll certainly include the link in the show notes.
Absolutely, and I'll put in a shameless plug that folks are interested, they can contact Ashley, our administrator, who will make you aware and let you know when some class slots are available. And we'd love to have you come visit Comal County, Bulverde Spring Branch, north of San Antonio. The Pinnacle Conference is going to be nearby later on next month, and lots of exciting things in the San Antonio region that we'd love to have people come visit with. Be happy to share those experiences with everyone. So.
Very exciting. I wanted to just take a couple of moments to highlight some other aspects of San Antonio's amazing pre-hospital care. And one of your colleagues, Dr. Miramontes, has presented on changing essentially the approach to pre-hospital stroke care. And what he did was very interesting. He took the AHA chain of survival and sort of transplanted that onto the paradigm of pre-hospital stroke care, starting from the dispatcher. Just like in cardiac arrest, a dispatcher would, try and coach the bystander to initiate high-quality compressions. With Dr. Miramontes' program, they had taught the dispatcher to go through a quick, fast FAST algorithm to determine if it was a likelihood that the patient was having a stroke. And then ultimately, the end game there is to see if we can have an effective pre-hospital stroke tool or evaluation checklist that can help identify large vessel obstructions, those patients that have obstructions that would benefit from neurointervention. Can you tell us briefly about that program and the success you guys have achieved there?
Yeah, it's exciting. We're fortunate that we have a strong regional component that allows for communication among pre-hospital providers and emergency departments and continued health care. It was certainly built on the shoulders of the trauma system and was initially funded for trauma care and has morphed into include obviously cardiac and stroke, and we look at a few other areas, particularly disaster response for us in our area. But this collaboration and opportunity to routinely engage and have conversations allows us to do so many things. Early on, when we looked at STEMI care, we felt the need for including the pre-hospital component starting from dispatch. And so while most folks were looking at recording door-to-balloon times and following that, we were monitoring and measuring from our dispatch times to balloon because we felt that incorporated and gave us feedback for our entire EMS system. And so when Dr. Miramontes came into town and took over the leadership with the San Antonio Fire Department, he saw this and recognized this and had a particular interest in stroke care. And so he put these same principles in place with concentrating on the dispatch center and incorporating that into our quality assurance programs. And David's done a wonderful job with that and has spent a lot of time in the dispatch area working with our dispatch teams and supervisors, providing education and feedback and looking at how we've been able to provide success for this. Now, our challenges are, like the rest of the country, is trying to figure out how we can adequately screen for the large vessel occlusion, and this provides quite a bit of controversy out there, and so we're very much looking forward to additional data to come out and help us with that and the triage and screening criteria to go to comprehensive stroke centers, and I think there are a lot of people around the country who are in that same boat. But Dr. Miramontes has done a wonderful job, and we give him a lot of the credit when it comes to coordinating this dispatch incorporated process for stroke care and identification.
Very exciting, and I think we should also mention that you and I are working on a project together with NAEMT, the AHDR course, the All Hazards Disaster Response course, with an esteemed group of colleagues. Wondering if you could just tell the folks a little bit about that as well.
Well, you're the leader of this. I've been doing all the yeoman's work with folks, but it's truly a pleasure to be involved, and I think I was asked because I'm the old guy on the team, and it's fun to watch these young bucks do all the work that are involved with this. But NAEMT has looked and asked for this development of a disaster course, and when I saw that, my interest from response and the experiences I've had through the military, it just seemed like a natural fit. And then I had the pleasure of working much more closely with you, Faison, and so that's been truly wonderful. And then the rest of the team who are coordinating and putting this together, and we'll be ready for our introductory course at EMS World. But this is one of those courses that's not a standard just read a textbook and absorb the knowledge. We want to make it an interactive process, use a number of online resources, and integrate that essential team building concept as well. And so I'm excited. It's been fun to participate and look forward to our beta testing, and would encourage folks who are attending EMS World to sign up and be on the lookout for this course in the near future.
Very exciting. We'll leave it at that. We'll let that generate some suspense, but certainly check that out at EMS World Expo coming up this fall in New Orleans. Sir, thank you so much for your time. We are amazingly grateful. It's already been an hour plus, and you've worked your overnight shift. Just a couple of rapid-fire questions, which we ask all our guests, and there's certainly no need to answer in a rapid-fire fashion, so certainly take your time.
So I can use the excuse I've been up all night. I have caffeine when I don't make sense when I answer. All right, go ahead, throw them out.
If you could travel back in time to your 30-year-old self, and if you could just provide us some context of where you were at that particular point in time in your life, what advice would you impart or words of wisdom would you have for yourself?
So when I think back to 30 years old, it just seems like not that long ago. I was a active duty military physician, and really at one of the prime areas of my life with response to different events throughout the world. Being an emergency medicine physician, and just involved in a lot of things with, that was a particular time for engagement and involvement with the mobile field surgical teams and critical care air transport teams. And so truly an exciting opportunity that has led to many things down the road that have blossomed. If I look back on that, though, I would say that at those points in our career, we're in our prime and we're engaged in career building activities. And I can say that I didn't heed the lessons of my forefathers, probably of spending enough time with family and making sure that I incorporated the activities and the priorities that go along with that. And so I would say those are things that you often hear, but I would just add the emphasis on for anybody in this profession at whatever level you're engaged with, again, assorting those priorities, making sure you're finding the right balance, and incorporating those lifestyle things that will have an impact for the rest of your life. So.
Thank you for that. You've had an amazing career, sir, and too many accomplishments to recount. Can you recall a particular challenge you faced as an EMS medical director in changing culture as the evidence-based advanced? So I guess, we talked about spinal emotional restriction and how difficult it was to change the culture. Can you recall another scenario where it was incredibly challenging but the right thing to do for patient care to change the paradigm?
Yeah, I think being engaged with an agency that was proud of the extent of the care that they were providing based on the number of medications that they had, that we were able to increase and provide from, I think they had a baseline of maybe 13 or 14 medicines, and when I came on board we increased that to 20 or 25 medications and things like that. But the challenge was getting them to understand that it was not the number of medications, but it was really the capabilities and the appropriate utilization of those resources to improve patient care and to assure that, again, it was a patient-centered organization, that we were doing things on behalf of the patient. And yes, it may have required more training. It may have required more emphasis in a particular area. It may have changed response capabilities to go along with that, and working through all of those issues. But again, trying to assure that there was a patient-centered focus and not having that focus elsewhere, I think, was probably the biggest challenge. And I don't know that I used all the methods that may have made me successful in that particular realm, but I certainly felt that I was staying true to that model and that mantra of improving patient care that was out there. And so I think that those challenges are faced by many emergency medicine physicians and EMS medical directors, and it's easy to succumb to external pressures or make life a little bit easier, but it's our job and our role to make sure that we're protecting our patients and providing the best care possible. We recognize we may have some limitations in resourcing, funding, and those sorts of things, but we still have to have that primary foundation of a patient-centered process.
Absolutely. And the last question we ask, which you've already answered, but is, do you have any asks or requests of the EMSNation audience? And I would just ask you to sort of re-highlight what folks can do to make a difference on the current legislative efforts.
Yeah, the time is now, and don't delay. Again, if you have not, or your congressman or senator has not signed up to support House Bill 4365 or Senate Bill 2932, please do that today. As you're listening to this, get off the phone, look on the get off the podcast, look at the organizations we talked about. Find out who your folks are, and just a simple call to their office saying that you're a pre-hospital provider, you're an EMT, you're a paramedic, you're an EMS physician, and we need the legislator to support this bill, have them sign on and understand its importance and the impact it would have to you and our patients if you were not able to administer a controlled substance, administer an analgesic, a benzodiazepine, what impact that would have on your patients if you were not allowed to do that with current standing orders and you had to contact a physician or online medical control every time you wanted to do that sort of thing. And so with that, that's our call to action, our call to arms. is let's get this done, and then let's move on to something else even more fun and exciting. But this is important, and let's take care of this issue up front. Thank you so much for having the voice and the opportunity to share this with many of your guests, and I hope you will do just that you'll take heed and ask for the support as you enter this advocacy world of things. And I thank you for that participation.
Dr. Manifold, thank you so much for your time. I very much appreciate it.
It's always a pleasure, and I look forward to our next meeting in person.
Thank you, sir.
All right, great. Take care.
Thank you so much, EMS Nation, for listening in. Dr. Manifold is truly an inspiration, and we are so lucky and honored that he joined us for the show. We would love to hear your feedback. Please find us on Facebook at www.facebook.com/prehospitalnation and let us know what you think. How are the issues that we're discussing affecting you? What are your thoughts on an EMS-based fire service? And could that potentially be a model where you live and where you operate? Finally, let's certainly take Dr. Manifold's call to action to heed and write our legislators discussing this incredibly important both House and Senate bills, which are currently on the floor, and let folks know that we indeed intend to provide the highest quality pre-hospital care possible, and we want the best for our patients. And we just like to throw out a shout out and message. We will be traveling to EMS Gathering coming up in Killarney, Ireland, as well as Smack Dub in Dublin, Ireland, in the month of June, just a couple of weeks away. So if you are a listener to the EMS Nation podcast, please stop us and say hello. This is Faizan Arshad wishing everyone a safe tour.
Hey friends, I'm going to take a brief moment to pause the show and bring you a word from our sponsors. No, not the sponsors you may traditionally think of, but rather sponsors that are aimed to help eliminate healthcare disparities. This is a very special project I'd like to announce during EMS Week for folks to trial. It comes at absolutely no cost and is ultimately designed to optimize your training experience and help translate into improved outcomes within your community in relation to out-of-hospital cardiac arrest. Recently, a group of colleagues of mine and I had the pleasure of coming together and reviewing the science and literature on feedback in CPR, and the data pretty much speaks for itself. Dr. Bobrow, the state EMS medical director of Arizona, has done tremendous work on this, and we now know that all the major defibrillator companies come with some sort of active CPR feedback. Nevertheless, we are acutely aware that once you know a single EMS system, you know a single EMS system, and budgetary constraints are real-world problems and challenges. Not everyone can afford the defibrillator component to their device. So what have we done is designed a watch app for the Apple Watch called Perfect CPR. Now, we should be very important to state this is designed for training purposes only, but nevertheless, once a provider opens up the app using the accelerometer and gyrometer built into the Apple Watch, you will be able to get direct feedback on your rate, depth of compression, as well as recoil. So please check this app out. It is available at $0 in the Apple Watch iTunes Store and is called Perfect CPR. Please also find us and follow us on Twitter at Perfect CPR. Again, we're beta testing for this, very excited to launch during EMS Week at a cost of $0 and would love your feedback.